Are we doing this morning? At least it's morning for me here in Denver. Dave's got something going on at his kid's school today, so I'm going to be handling things for us this morning. First thing I'd like to do, if somebody can kind of fill me in on what you guys went over last week. Dave and I talked about it very, very briefly, um, particularly if there's any particular questions that you guys have about what you guys went over last week. So anybody want to jump in and kind of fill me in on what that was all about? Well, what the last week's Zoom was all about?
Yeah, last week we did cases
Gotcha.
specifically on evaluation of the shoulder.
Okay.
Um, I think more so to see, not so much as to like if we could name like scapular depression syndrome or any of those, but more
Yeah.
so to say like, okay, if someone's presenting like this, where might you look elsewhere? But we didn't hugely get into the biomechanics, just more so kind of spitballing up how the clavicle may play off of the scapula, which may impact the thorax, and just to see if we were kind of on the right brain wave of like where could you look next.
All right. Well, that's actually pretty good because that's pretty close to what I wanted to go over today. I have a case for us. Um, and there's going to be some things in this case as far as looking at some of the biomechanical examination processes that you guys just won't know yet. That's you're going to learn them in this next on-site intensive, right? So hopefully that'll be all right. Hopefully there's no major confusion. You guys can kind of get out of the I need to know exactly what's going on with what. But that's good. Hopefully that'll make some sense. Did you guys have any questions about the case from last week? I don't know what the case was, but if there's anything specific from like a concept perspective, I'd be happy to answer those before we get into the one that I have prepared for today. Hey, Kyle's here. I thought he was going to be going. Nothing? All right. Well, let me pull up, make sure I can share here. Pull up the little case scenario that I wrote up, and I'm going to apologize ahead of time because I literally found out that I'm doing this last night at like 8 o'clock, and so I kind of just threw this together this morning. As far as this little PowerPoint thing, so if there's some inconsistencies here, that's going to be my fault. I'll talk about what's really going on as we go through it, but hopefully everything kind of matches up with the actual case scenario. So. Um, the thing that I wanted to go over today is I wanted to look at a case that affects the shoulder girdle that has some other influences, either through the CT junction, cervical spine, AC joint, all that sort of stuff, and kind of how it might present when this person walks into your clinic, right? So, this person is a person that I saw, and honestly, this is going to be a very common case, to be honest. So hopefully, this will be one of those things that you guys look at and you say, "Oh, yeah, I've seen this person come into my clinic." Whether or not they have the same sort of occupation or any of that sort of stuff. I feel like this is a very common presentation. So, kind of jumping into it, the person that walks in, 42-year-old male, comes into my clinic complaining of right-sided anterior shoulder pain. Okay, and it was a gradually progressive issue that had started about 6 weeks prior. Okay, so insidious onset, nothing, traumatic, nothing that set this thing off. It just started kind of gradually getting more and more irritable over some time. All right, so first thing you do, I'm going to go through my subjective exam here. I'm going to ask a handful of questions. We're going to try and kind of start steering you guys into the process that we want you guys to have when you're actually examining patients, right? So we initially talked about kind of the first couple of modules is somebody comes in, you want to go through a scan exam, right? Cervical scan, lumbar scan, thoracic scan, all these sort of things. But realistically, when we get into the real world of being in the clinic, right, we don't want to have to spend all the time going through a scanning exam. Now, a scanning exam should only take maybe 15 minutes, kind of at the most, really realistically. But we want you guys to have the scanning exam as more of kind of the fallback, right? Because the idea should be is you start recognizing some patterns, right? Some profiles of dysfunction that walk in the door and you're just like, okay, I see what's going on here with this thing. I'm going to ask him a couple questions to kind of, elicit some other subjective information from this person, that's going to point me in the direction that I need to go. Right now, if you have somebody that comes in the door and they're telling you their story, and you're just like, you kind of look at them with your eyes a little wide open, like, oh my God, I have no clue what's going on with this person. Then it's perfectly fine to go back and do a scanning examination, right? And somebody comes in with lower back pain, and it's a profile that you don't understand, don't haven't seen, or don't recognize. There's nothing wrong with going in with and doing a scanning examination on that sort of person. Get that neurological imprint, determine, is this patient appropriate for physical therapy? Kind of maybe hopefully come up with some sort of working hypothesis as you go through it. But realistically, we want you to be able to kind of say, okay, yeah, this person is kind of steering me in this direction. So I have a couple of questions that would be specific to that particular pathology that I have in mind. Again, somebody comes in and they read me this, right? They tell me, they take their note card out, and this is what the person is dealing with. I should immediately have three, maybe four hypotheses in mind, right? Patient comes in with complaints of right anterior shoulder pain. Okay. Gradually progressing over the last 6 weeks, no particular trauma. All right, great. So instantaneously, my brain goes to, um, you know, maybe bicipital tendinopathy, maybe a rotator cuff tendinopathy, maybe a labral pathology, maybe an AC joint dysfunction, and instantaneously, I have four potential hypotheses in my head, that could be potentially the source of this problem, right? So when that happens, and you say, okay, this is where I think this might be coming from, you should immediately have some questions that come into mind, right? So if it's a bicipital tendinopathy, is it worse with overhead activities, right? Maybe cross arm activities. If it's sorry, if it bicipital, did I say bicipital tendinopathy? Bicipital tendinopathy, worse with overhead activities, worse with cross arm activities, things of that sort of nature. If it's a rotator cuff issue, is it worse with lifting, worse with loading, and then also potentially with overhead activities? If it's a labral issue, is there clicking, clunking? Is there some sort of potential instability? Other things that you can ask about as far as instabilities go. If it's an AC joint issue, again, does it hurt when you lay on it? Does it hurt when you reach across the chest? Things of that sort of nature. There's specific um, kind of characteristics that you find of some of these pathologies that you can ask the patient about. And those things should, again, we're looking at kind of these proportionate numbers, when we're trying to make these diagnoses, that says, if I ask this question and they say yes, if I say, is there any clicking or clunking in the shoulder, and they say yes, well, my labral pathology number goes up, right? If I ask about cross arm stuff, well, then I'm looking probably much more at a potential impingement issue, or maybe some sort of AC joint problem, right? And those numbers go up, right? So as far as that goes, that should be the way that your mind operates as far as, you know, planning out your subjective examination, is having those questions in mind, because they should be pointed, direct questions, that can allow you to help to differentiate between one potential hypothesis and another. Okay. So that's kind of what we're going to go through here. So my line of questioning kind of goes down this line here, right? So asked him, how did this thing start? What was the onset? Well, it started insidiously. Um, Mild ache, in the anterior shoulder, was only really present with work activities. So the next thing I ask is, what do you do for a living? Well, I'm an electrician. I do a lot of overhead light installations, things of that sort of nature. So working up in these general vicinities quite a bit. So a lot of overhead activity for this guy. A lot of sustained overhead activity for this guy. Okay, so after the first 2 weeks, the pain continued to worsen, got up to about a 5 out of 10, and started to become an issue more with daily tasks, like, washing his hair when he's showering, getting dressed, so getting his arm overhead to put on a shirt, things of that sort of nature, combing his hair, all that sort of stuff started to get more and more difficult. So now we're dealing with not with just the function from the occupation, but also just with, you know, moving around during the normal day, right? So, did take a week off of work, um, after those first 2 weeks, and the pain started to subside. Okay, so a lot less overhead stuff, a lot less loading, a lot less lifting, all of these different things. Took the week off, thinking, hopefully that'll help things out. Went back to work, and within that first week, the pain came back. Okay, so started getting back into the overhead stuff, and there it is again, right? So again, you're looking at this from a perspective of this is an insidious onset problem. There's no trauma. It's just like this has got to be one of those kind of either forced overuse problems or, excessive strain problems or excessive compressive types of problems, right? So those sort of things tend to start becoming much more obvious when you're looking at this sort of situation, especially with insidious onset stuff, right? So had to ask the question. No prior history of shoulder problems. Wasn't an overhead athlete as a youngster. Didn't, hasn't had any falls. The only thing that he did mention was a rear end motor vehicle accident. So he was hit from behind about 8 months prior to this starting, and that may or may not be relevant, right? We take that into consideration. We say, okay, well, what could that have done potentially? Could that have damaged the shoulder at any point? Well, if it damaged the shoulder, odds are the patient would have known that as it happened, right? So when we look at trauma, right? So a motor vehicle accident potentially maybe damaging the shoulder, was it against the steering wheel sort of thing, or did he, get the shoulder against the what's the damn thing called? Seatbelt. Any of that sort of stuff, it's just like, oh, well, if there was a particular trauma to that tissue, usually that happens pretty quickly, right? So if there's significant structural damage that occurs with a trauma, we expect the pain to occur very quickly, within a few minutes, right? That might mean, structural ruptures, tears, things of that sort of nature. If it's something where we have, a particular type of strain where nothing is completely ruptured, so let's say maybe a rotator cuff injury where you strain something, it doesn't feel so bad for the first 8 to 12 hours, maybe even 24 hours, something like that. Um, but then it's kind of that next morning you wake up with the pain. That's just the amount of time it takes for the swelling to build up, and for some of that pain response due to the buildup of inflammatory exudate within the tissue, and that's kind of how that happens. We see that a lot with disc injuries. Somebody going to lift something out of the rear of their car, the trunk of their car, and they tweak something, and it's just kind of like, oh, it something doesn't feel quite right here, but you can kind of get through the rest of your day, and then they wake up the next morning with, debilitating back pain, maybe even potentially leg pain. That's kind of the typical, buildup of inflammation that will occur with kind of that, grade 2 type of lesion to some sort of soft tissue. All right, so um, he didn't have any of that sort of stuff, at least not associated with the shoulder, right? So had that motor vehicle accident a few months prior, and that will become important as we go through this. So by the time he came in and saw me, he was having pain first thing in the morning. So woke up in the morning, shoulder was painful, it bothered him. So naturally, I would ask, and I didn't put this on here again. Like I said, apologize for not having everything on here, but um, I'd ask, what position do you sleep in typically? He says, well, I typically sleep on my stomach, my head turned to the right side. So kind of laying like this, arms up overhead like that, right? And so he started waking up in the morning with increased pain. It would kind of decrease as he starts getting ready for work and gets himself out the door. But by the time he's done with work, and this patient has had, 8 to 10 plus hours of a lot of overhead activity, it was worse by the time he got home, right? And so not very comfortable when he got home, not able to do a whole hell of a lot after that whole day of work. And so it kind of starts just lending the idea that, yeah, these overhead positions, anything where that arm was going to have to be overhead was going to be really difficult for him, right? And so kind of makes you start thinking, maybe this is an impingement issue, right? Objectively, right? So the first thing when I'm looking at a situation like this, there's multiple options here as far as where this may come from, right? Because if I'm thinking this is going to be an impingement problem, I'm leaning more toward either the bicipital mechanism, so bicipital groove issues. And when I say bicipital groove issues, I'm looking at the tendon itself. I'm looking at, potentially the transverse ligament that goes across the top of that. I'm looking at potentially some of the musculature that attaches to the bicipital groove. So that would also include things like the pec major, the lats, the deltoid, things of that sort of nature that actually attach to that general region, right? And so any one of those things can be irritated by an impingement problem. Um, but when we're thinking about that, we have to say, all right, yeah, something's getting compressed here, right? There's a force that's coming down on this thing, and that may be the thing that's kind of setting us off. But why, right? Why does that happen? We have to determine diagnostically what tissue is it so that we can unload that tissue, right? But in the grand scheme of things, the way we end up treating this is we have to unload we have to be able to correct the biomechanical faults that are creating this compressive problem. So we have things like scapular dyskinesias. It's kind of a very broad, generalized term. It just means the scapula doesn't move in sync with the chest wall, in sync with the glenohumeral joint or the humerus itself. And so we just have this abnormal movement pattern associated with how that scapula is supposed to kind of swing and move relative to the chest wall and again, then relative to the arm itself. So that could be an issue. Probably the most common reason for that sort of thing to occur is cervical facilitations, right? So it's going to affect the musculature around the scapula, and it's going to affect basically the ability of some of those parascapular muscles to lengthen, right? And if that happens, if we have hypertonicity or relative hypertonicity of one particular muscle group based off of a cervical dysfunction, then it's going to affect just how well that scapula is able to move relative to the other structures around it, right? And so that becomes a very significant problem. It's kind of one of those things, and I'll tell you guys this right off the bat. When I see that sort of thing, it's just like, damn it, it's so much more complicated to deal with that sort of problem because it means you have to go and deal with the whole neck. Because some of the other issues that you might run into, a CT junction limitation, like a stiff upper thoracic segment or a rib issue or something like that, it's like, oh, I can go in and manipulate that and I can free this thing up very quickly. If I have to deal with a neck issue, there's a whole lot of other problems that come along with that as far as down ramping, the facilitatory effects. How do I improve movement of the, potentially limited segment within the cervical spine or within the upper thoracic spine, CV region, all of these different things kind of come into play. And then after that, you start thinking about, well, there could also be, maybe an instability in the glenohumeral joint, especially if the patient has had prior traumas, or do they have a lack of mobility through the shoulder girdle, right? So when I talk about the shoulder girdle, and maybe this might be even a touch different when Dave talks about it, but I'm looking at the ACSC sort of components, right? So how does the clavicle move relative to the scapula itself? How does the clavicle move relative to the sternum, right, to the manubrial junction there? All those things have to come into play, and so there's a lot of different things that you have to look into. So when I'm looking at observation here, right off the bat, the first thing I'm going to look for is just what's the scapular position. It's just the easiest thing to kind of try and see. Is there some sort of abnormality in scapular position relative to the opposite side? Now that will obviously mean that you have a unilateral dysfunction, right? If you have a bilateral dysfunction, pretty universally, you should be thinking there's a centralized problem, right? There's something coming out of the spine. And it's probably going to be some sort of adaptive hypermobility or instability where it's affecting both peripheries, left and right, right? So that should be the immediate thought process if it's bilateral. But if it's unilateral, you want to see what is the difference here. And so when I'm looking at this patient as they come in, they had an elevated scapula on the right side. But what we were really seeing was if this is the two scapulae, is I was seeing this, right? So the superior medial angle of the scapula on the right side was up, and it was up a pretty substantial amount, almost a full inch, something like that. And that's going to tend to suggest that, yeah, this isn't just how this person's posture rests. It's not an arm dominance issue, things of that sort of nature. When we're sitting in this sort of position. So the scapula was elevated on that right side, but the AC joints were level. Okay, so what that means is I've got this sort of thing. So the far end here, where the AC joint would be, it hasn't changed positions, but I've got this kind of abnormal position of the scapula medially, more toward the spinal gutters and such. Right, so that's the first thing I noticed. There was some mild protraction, right? So the shoulder kind of rolled forward slightly on the right side. So that can definitely be something that's relevant, because that could potentially mean, changes to potentially the pec minor as far as muscle tone goes, or maybe the upper fibers of the serratus anterior. Okay, so the last thing, these are kind of gross things that you see, just observing somebody. Bit of a forward head posture and definitely an increased upper thoracic kyphosis. Um, I mean, honestly, how often do we have somebody come into the clinic with shoulder issues and they don't have an increased upper thoracic kyphosis, right? It just seems like it's such a common problem. Um, but those are definitely things that we have to take in consideration, because if I'm looking at this and I say, well, maybe that upper thoracic spine doesn't move very well, that's probably something I need to go in and take a look at, right? And the forward head posture, like I mentioned, that's again going to be something that we're going to have to take into consideration. All right, kind of small print here, but you guys can probably manage. So, continuing with the objective stuff, looking at the range of motion, the first thing that I wanted to look at is I want to look at how the arm moves, right? I just want to see, can they get this to this position? Can they get to that position? Do any of these things reproduce the discomfort that they're having? So I just had, say, go ahead and lift that arm up and overhead. And on the right side, it was definitely limited, only to about 170 degrees. Now, an average person with full overhead reach probably gets anywhere from 190 to 200 degrees, right? So a full 180 degrees is where the arm gets basically even with the trunk, the midline of the trunk. But most people, if they start adding in that upper thoracic mobility, can get beyond that, right? And can get up into that 200-degree range. And that's very common. So if somebody kind of lifts that arm up and they can only kind of get to here, and now it's starting to reproduce pain, um, yeah, that means it's likely limited, especially if you're looking at it from a perspective of what does the right side do? Now, what can the left side do? So, in this particular patient, got to 170 degrees, did have a reproduction of pain, and the pain increased if I overpressed it, if I tried working it backward a little bit further, because I wanted to get an idea of, what potentially might be the end feel here. Is this going to give me some sort of spasm or any of that sort of stuff? And then when I asked them to put the back of their hand, onto the small of their back, that also reproduced pain. It wasn't limited, but it did reproduce pain. Okay. Looking at the shoulder itself, one of the major things that I'm always going to look at is external rotation. Okay. External rotation, if it's substantially limited, tends to suggest there's a capsular issue. That's just going to be the most limited, um, plane of motion that you'll get in the glenohumeral joint. So, there's also some limitations of external rotation that'll occur if you have a humeral head dysfunction. Very common problem. It tends to have a different end feel. Um, since not so much a capsular end feel, it tends to have more of an elastic end feel, some more muscular issues. And one of the things that'll happen with that is if the humeral head has started to slide forward on that glenoid rim. So it's actually relatively similar to a euphor, that we can have now there. Now, it doesn't tend to be a primary problem, in the shoulder, like it does in the hip, right? So if we have a runner, that's increasing mileage or training for a particular activity, and they start developing anterior hip pain, you can develop a euphor because of the change in training routine, right? So that sort of thing does happen, and happens a lot, actually. It's not usually the case with the shoulder. Usually the shoulder gets forced into these anterior positions because of some sort of limitation proximal to that, right? So maybe AC joint, maybe upper thoracic spine, or limitation of scapular mobility due to a cervical segmental facilitation. So this particular patient did not have a limitation of external rotation. So if I just had the arm down here at the side and I'm just looking at external rotation in that sort of position, left and right was pretty symmetrical. Okay, so at that point, I'm looking at it and I'm saying, I'm pretty comfortable saying this is probably not going to be a capsular issue of the glenohumeral joint, which is nice from our perspective because capsular issues of the glenohumeral joint, they just take a long time to kind of correct, right? I mean, we know that when we're dealing with capsular issues, the treatment of choice is going to be passive, progressive, likely oscillatory mobilizations, and those things just take time, right? We tend to stretch this tissue out and we regain a little bit of mobility, but then it's going to almost always recoil after we're done a little bit. So we're hoping for that two steps forward, one step back sort of scenario when we're dealing with capsular issues. So in the shoulder, because of its significant amount of mobility, it tends to be one of those areas it's just hard to deal with because there's so much mobility you have to regain. Um, was a mild limitation of abduction, abduction, so just coming straight out to the side here, and then a moderate limitation of cross arm adduction that actually did reproduce pain. Okay, so that could have a couple of implications. Um, Number one being if we have a limitation of cross adduction, adduction, one of the major areas that might be limiting that is the AC joint. Right. So as soon as we start seeing a limitation of cross adduction, we have to think, yeah, we're probably going to have to go in and do a bit of an examination here on the AC joint to determine how it's moving. Okay. The increased pain, however, tends to suggest that that cross adduction position increases potentially some impingement position, right? And so that could be any number of things. It could be, reproduction of pain of the AC joint itself. It could be the bicipital mechanisms, or even potentially, probably less so from a percentage standpoint, but also potentially the rotator cuff. Okay. Um, as far as resistance testing goes, patient had a significant increase of pain with the biceps load test. So I don't know if I've shown you guys this at all. I've had about a million different courses that I've done in the last 2 months, so I can't remember which one was which. But the biceps load test is the one we're starting here, and kind of about 30 degrees of flexion, and I'm asking him to resist, looking for reproduction of pain, and then I'm dropping the elbow behind the shoulder and resisting the biceps again. And what this does is if we have the bicipital groove here, it's just when we have the arm forward, the tendon will bowstring. It'll pull away from that bicipital groove, and so it can very easily reproduce pain if we're dealing with something that overlies that bicipital groove. So that could be that transverse ligament that goes across the top. It could be the pec major, which also crosses over and goes to the lateral edge of the bicipital groove. But when we drop that elbow backward, what we do is we seat that tendon into the groove very substantially. So if we end up having diminished pain with the elbow behind the trunk, then we're probably more suspicious of either that pec tendon or maybe that transverse ligament. This patient ended up having pain with both positions, so it tends to suggest it's the biceps tendon itself because it's the same sort of idea when we go through and do the patellar tendon tests, right? If we test it in multiple planes of range of motion and it's painful in all the planes, we tend to think it's the tendon. If it's only painful in one particular range of motion, we tend to think it's more likely to be the articulation of the patella with the femur, right? And how that changes based on the particular range of motion. So in this particular patient, it was painful in both positions, so we're leaning more toward the biceps tendon. The speeds test, not my favorite test in the world, but it can be useful, right? And it's a decent correlation test that we can use. So hand out, palm up, looking for resistance there. That was also painful on resistance. So we're in pretty good shape as far as thinking, yeah, maybe the biceps tendon is our pain producer. Went ahead and did a full can test, right? So that's just thumb up about in the scapular plane, so maybe 30, 40 degrees of abduction, horizontal abduction, resisting there for the supraspinatus, dropping down into a 90-degree position, so elbow at the side, 90 degrees of elbow flexion, and resisting external rotation. No reproduction of pain there. So as far as the posterior cuff structures go, probably feeling pretty good about the idea that they're not involved as far as pain reproduction. Um, did not have pain with resistance of cross adduction. So this is just I'm here and I'm asking them to pull across, right? So now I'm testing the pec major, or at least I'm trying to test the tendon of the pec major because there's some various angles that you would have to go through if they were having more chest related pain, depending on if you're looking at the clavicular insertion and maybe the sternal insertion of the pec itself. But if you're just looking at the tendon, you can just test cross adduction. That's going to be plenty. And shoulder depression. What I'm testing there is I'm bringing the arm out kind of to this position. And I actually kept them in a pretty neutral position, and I'm having them pull down toward their trunk to test the shoulder depressors, more specifically the lats. Okay, so neither one of those reproduced significant pain. So again, the bicipital groove muscles, right? We have three of them. We have the pec major attaches to the lateral edge, the lats attach to the medial edge, and then the deltoid will attach kind of the very inferior portion of the lateral edge of the bicipital groove. So as we're going through and doing all these tests, we can kind of make a differentiation here saying, yeah, it looks more like it's going to be a bicipital tendinopathy based on the resistance tests. All right, so the next thing I did is I went right in and I did a couple of stress tests. So I was interested in the glenohumeral joint ligaments. And again, these are things that you're going to look at during the on-site course intensive. Um, there's various ways of testing these, either with an anterior translation or an inferior translation. We can look at the superior, the middle, superior band, the middle band, and the two portions of the inferior band. There's an anterior and a posterior portion of the inferior bands. Um, and so you can kind of play around with those sort of things to see if any of those are positive for either laxity or for reproduction of discomfort. So again, you'll learn how to do those things during the course, the on-site course. So I'm not going to go over that stuff now. But those again, they were negative, so we're not looking at any potential passive stuff there as far as the ligamentous structure goes. The capsular drawer test. Um, is one of my favorite tests for the shoulder, believe it or not. It's a based off of the lack of limitation of external rotation. I'm not terribly worried about the joint capsule at this point, but if I wanted to test the joint capsule itself for any laxity potentially, if I take the arm and I just pull down along the line of the humerus, producing this inferior translation of the humeral head, I should have some give there, right? There should be a little bit of play. This is just the laxity in the joint capsule, right? And so that should be there. But if now all of a sudden I externally rotate the humerus, I should tighten the joint capsule, right? And so what I should get is less play if I produce that same inferior translation. Now, if I do that and I continue to have the same amount of translation, it suggests the joint capsule is slightly insufficient, at least anteriorly. Now, I could also internally rotate the shoulder and produce the same traction. That would test more the posterior capsule. Posterior capsule is much thinner. It's very flimsy almost. So again, you can use this as a stress test for reproduction of pain, or you could use it as a stability test to test for laxity if you want to as well. Okay, so it's a really kind of a cool test, and again, something that you'll learn during the on-site intensive. Anterior load and shift. Again, you can do anterior and posterior with this. In fact, that's how it's described in the literature. But since the pain is anterior, we're really only concerned with the anterior component. This is testing for the labral um, structures, right? And so the idea here is you compress against the glenoid rim and you just try and shear that forward again, looking for it's going to slacken off the ligamentous structure. It's going to slacken off the joint capsule. And so we're really just looking for, how does that labral tissue at the front of that joint rim, how does that sustain stability there? Is it capable of doing that? And so you can assess either for excessive motion or potentially reproduction of pain. And with this one, you may also get clicking or clunking, right? So that's another good one. There's about three or four others that you can look at for the labrum that I think are in our curriculum. Things like O'Brien's test, the biceps. There's another one called the biceps load test, which is done kind of up here. It's more for a slap lesion than like a Bankart lesion, an anterior um, labral pathology, something like that. So again, these are tests that you'll learn during the on-site intensive. But so when I'm looking at this, I'm just saying, is there any reproduction of discomfort here or any laxity that I need to be aware of, particularly when I'm looking at, how am I going to rehab this person? Once I do my manual therapy, I have to do my rehab components, where I'm going to take them through some exercise stuff, maybe movement re-educations, things of that sort of nature. And so it does help me with that sort of situation. So again, based off of the results of this objective stuff, the biggest thing that I'm getting is I'm getting it right here. As far as the pain with the biceps load test and the speeds test, my diagnosis is very easy at this point. I'm looking at a biceps tendinopathy. And it's more of a tendinosis at this point, would be my suspicion, because it's been several weeks since the patient started having this problem. So if it was more acute, we'd think of maybe a tendonitis, and that might affect how we're going to treat this as well, because we might start thinking, well, we have to get out of the active inflammatory phase, maybe some more palliative type things, um, more modalities and things of that sort of nature to kind of get out of that active inflammatory stage before going in and doing anything, major to the rest of the joint region. Any questions about how I got to that point before I move on to the etiology stuff? Nothing? Okay. Oop, skipped over one. Here we go. All right. So the etiology, and again, this is part of the process. Once you find what tissue it is that's damaged, that's actually producing the pain, it should give you some ideas about what potentially is causing the problem. Now, in the shoulder, I'll be honest with you, it's actually pretty simple. Um, Most of the issues that you're going to run into are going to be some sort of impingement problem, right? Maybe an instability. Um, but they're almost always caused by proximal movement dysfunction. So loss of movement of the upper thoracic spine, poor scapulothoracic rhythm because of muscle tone changes, because of a cervical facilitation, maybe a post-traumatic fibrosis or capsular limitation of the AC joint. Any of these sort of things can limit mobility proximally, and so it pushes all the mobility that you have to maintain distally. So down to the glenohumeral joint, and that affects the ability of some of these tissues to kind of manage, right? Every tissue in the body has an adaptive potential to deal with excessive stress, but it always depends. Like, how long does it take before you exceed that adaptive potential and the tissue starts to break down, right? So we need to find the reason for this tendinopathy with the overhead reach issues. So the stuff that he does with work in particular, things like washing his hair, with getting dressed, the loss of cross-set adduction. I'm really thinking impingement issues is going to be the major problem here with this patient. So I'm looking for a limitation. Where is this person limited? All right, and what do I have to do in order to fix it? Okay, so here's my process. And again, I threw this together very quickly this morning, so I kind of hope this would be, a little more linear. Um, But the first thing I'm doing is I'm going to do a quick cervical screen. The first thing I'm going to look at is cervical rotation. I'm just going to say, okay, turn your head to your right, turn your head to your left. Do I have some sort of limitation there? Um, that's my first little test that I'll do, right? And it's basically just to say, do I need to dive deeper here? Right? Do I need to go in and do a full cervical biomechanical examination here to determine, is this a factor potentially with some of the periscapular muscle tone, right? And that's a very common problem, very common problem. Okay, so that'll be the first thing I look at. After that, I'm going down to the CT junction. So I'm gonna again even I can bottle these two things up together. When I ask them to look left, look right, I can get fingers on the articular pillars of the CT junction. So when they turn, do these things. If I turn to the right, does the right side extend? When I turn to the left, does the left side extend? Looking at, cervical flexion and extension, same sort of idea. Do I get extension when I go into cervical extension? Do I get flexion when I go into cervical flexion? And then I may even look at inspiration and expiration. When I take a breath in, I should get some extension of the cervical of the CT junction facet joints. Same thing with the ribs. Do those upper ribs, those rib tubercles, do they descend with inspiration, giving me that pump handle movement that I should be getting in those upper thoracic segments. So real easy screening test, and it actually almost doubles as part of my biomechanical exam, right? Because those things you could really legitimately say you're basically just doing PIVMs there, right? So that's an easy thing to jump into next. Then I'm going to look at the shoulder girdle. I've already done a lot of this at this point, right? In part as part of my diagnosis process. I'm looking at cross adduction. That's a big thing for the AC joint. Shoulder abduction. That's another big thing for the AC joint. And then for the next thing that I'm going to do is palpation. So if I look at palpation of the AC joint, if I get right on to the posterior aspect of the clavicle and I take that all the way to the distal end of the clavicle, there's this little V shape between the end of the clavicle and the spine of the scapula, right? And if I drop my finger right in between those two landmarks, and just kind of friction across the two of them, if the AC joint's painful, that's where you're going to find a reproduction of pain from palpation. It's very easy and it's absolutely pretty universally effective. Okay, if I go right over the top of the AC joint, or if I even come to the front of the AC joint, it almost never is going to give me a real good feedback as far as whether or not that tissue is painful. Kind of similar to the Achilles in that sort of regard. If you rub over the back of the Achilles, there's so much thick fascial tissue. It's almost like that silver skin you get on a piece of meat. For those of you that do any grilling or things of that sort of nature, it's just this real thick, leathery type of tissue that just doesn't allow you to get into the actual tissue itself, right? So you kind of have to go toward the front of the Achilles in order to get a good feel for the palpatory exercise there. It's the same sort of thing for the AC joint. You got to drop off the backside of the distal end of the clavicle, get into that. There's actually a term for it, and I can't remember what it is off the top of my head. Some sort of angle. It might be just called the scapular angle, something like that. Um, so if you get right into that spot and it's reproducing their pain, then you're pretty comfortable saying that it's the AC joint itself. Okay, so that'd be the next thing in the step there is we're just kind of working proximal to distal, so cervical, CT junction, shoulder girdle, and then I'm looking at the glenohumeral joint, which we already have done as part of our diagnosis process. So that's just me looking for a capsular pattern. Do I have a loss of external rotation? Does that, significantly worsen if I bring them out into an abducted position? Things of that sort of nature. You'll learn about the scapular quadrants, sorry, the glenohumeral joint quadrants during the on-site course as well. It's funny. It's always funny to me when we talk about glenohumeral joint quadrants because there's actually five of them and not just four. So always interesting that they're still called that. But that's something that we can go into as well, looking at the glenohumeral joint itself. And then we're just going to assess our findings, right? And so the first thing that we need to do is we have to have a hypothesis for what the etiology is, right? So if I've gone through these things, these four things here, I should have a pretty good idea by the time I get to the end of this to say, here's my hypothesis. Do I need to go back and do a biomechanical exam of the cervical spine? Do I need to go back and finish, kind of the relative biomechanical exam of the CT junction, et cetera, right? So the process should be pretty fluid, and it should take you from A to B to C pretty quickly. Okay, so if I'm going through that process, here's what I end up finding. So I'm doing my cervical screen, and then I'll just go ahead and lump in the biomechanical exam findings. Feel like I've been pretty obvious that there's going to be some. So there was a very significant loss of right cervical rotation, limited by about 40%. So if you guys go back to some of the things that we've talked about with the cervical spine in the past. If we're limited by more than 30% in our expected range of motion with rotation, it tends to suggest that there is a craniovertebral joint issue, right? It doesn't tell us what the issue is yet. It just tells us that those top two segments, the OA and the AA, are very likely involved in the restriction. Okay, so that's a big deal. That's a very big finding. The patient did have cervical spine pain, so pain in the neck with right cervical side bending. So just tipping the head to the right. Yeah, I get a little bit of discomfort there. And it was limited by about 20%, which is not terribly substantial when we're dealing with side bending. Um, the limitation of right rotation of the cervical spine worsened when we took them into a craniovertebral flexion position. So if I'm here and I rotate and I'm limited by 40% and I put myself into a CV flexion position and it worsens that restriction, that tells me something very substantial. Okay. The OA joint will be affected by flexion or extension. The AA joint will not be. Okay. The AA joint is right on the line of flexion and extension. And because we have these reciprocally convex articulations, is we get kind of this little skidding motion that occurs in flexion or extension, but we don't get these big gliding motions that occur, for instance, in the OA joint. Okay, so change in limitation with flexion or extension suggests the OA joint is problematic. Okay, and again, we'll go through that much more substantially during the on-site course. Okay, so biomechanically, what we should have when we go into a craniovertebral flexion position is with the occipital condyle, so the skull essentially should glide posteriorly, right? So if I do this, the occipital condyles glide posteriorly on C1, right? So if I rotate to the right, what I should get is a posterior glide of the right side and the anterior glide of the left side. All right, so what we would check for then from a PAVM perspective is do we have a loss of OA glide on the right going posteriorly or OA glide on the left going anteriorly? Now, the fact that it worsened in flexion suggests it's the posterior glide on the right. Okay, went in and did some PIVMs and PAVMs of the facet joints in the mid-cervical spine. Found that there was some pain with extension on the right C2-3 segment. So 2 going into extension on 3 reproduced that same sort of, kind of dull, achy type of sensation that they had in the mid-cervical spine. Okay. Scapular quadrants. Boy, do I love these things. Okay, so quadrant testing, you guys all know that I'm a big fan. I'm a big fan of anything that's going to give me a lot of information with very little extra effort and extra time, right? So this basically is a combination of either elevation, depression, protraction, and retraction. Okay, so those are the scapular quadrants. So I could have, for instance, a elevation protraction quadrant, right? And so when I move in the cardinal planes with the scapula, so if I just go into a straight protraction position, really what I'm testing is the ability of the SC joint to move. If I go into pure elevation, I'm really testing the SC joint. If I start combining those two, right, protraction and elevation, now I'm testing the ability of the scapular, those parascapular muscles to lengthen. Okay, so if I go in and I start looking at these different quadrants, it's going to give me some feedback on various muscles. So in this particular patient, there was a loss of right scapular depression um, and protraction. Okay, so what I'm doing is I'm pulling the scapula down and I'm pulling it forward. And so the muscle that I'm looking for here with this, and I was going to ask this question, but we're running short on time, so I'm just going to give you the answer here, is the levator scap. Okay, so now I have reproduction of pain, cervical pain at C23, and I have a loss of extensibility of the levator scap, which is supplied by the C3-4 nerve roots, right? So 2-3, the nerve root that exits between 2-3 is C3, right? And then C3-4 would be C4. That's just the nerve root that exits in between those two. So I have a potential C3 issue here and a loss of extensibility of the levator scap. So now I'm looking at that position that I found initially where we have that elevated medial scapular angle, and it's starting to make a lot of sense. Right now, I'm thinking I have some hypertonicity of that levator scap, and that's probably affecting my scapulothoracic rhythm. Okay, my CT junction exam. Again, I've done a lot of this already because when I'm looking at them rotate their head and look up and down and that sort of stuff during some of my screening tests, if I have my fingers on those articular pillars, I already know that there's going to be something that's not moving. Right. The question then becomes, what's the end feel? What if I have them rotate to the right and this thing doesn't go, the right side won't descend, then I just peruse an imp glide, right? Inferior medial posterior glide on that articular pillar, and I assess the end feel of it, right? So as I'm doing that, I find that the 2-3 T2-3 extension with cervical rotation, cervical extension, and inspiration was all limited. Okay, and it's a pathomechanical infield. Okay, so we get all of that sort of stuff. Now, are there a couple of things that I can, throw in there to help me, feel better about that process? How good am I at my infield appreciation, that sort of thing? Well, I can look at the posterior scalene that comes off the second thoracic rib. Um, is there a change in tone there, right? So right in front of the upper trap, get into that. Does that have some trigger points? Is that tender? Yes. Okay. Should be tender on palpation. Checking for tenderness to palpation at the second rib costal cartilage, so the attachment to the manubrium and the sternum there, right? So that's that manubrial sternal junction, that little notch there where the second rib costal cartilage will come in. Is that tender to the touch? Because that essentially is going to get very twisted up if we're doing this kind of bucket handling motion as opposed to the pivoting that should occur between both the manubrium and the rib, right? So it should be a relatively null movement that occurs there. So again, both of those were positive on this patient as far as reproducing pain. Shoulder girdle. I knew that we were limited in cross adduction. So I want to see, can I get any anterior glide? Can I get the acromion to kind of swing around the clavicle to allow that sort of movement, which was not very mobile. Had more of a capsular infield, so more of a soft tissue restriction there. Probably just means at some point that tissue was a little irritated and a little inflamed as well. And then we had already looked at the scapular quadrants there as far as the rest of the shoulder girdle. Glenohumeral joint, we already looked at the ligament stress tests. Those were negative. Load and shift was negative, and we had full external rotation in neutral, which I think of as a 30-30 position. So 30 degrees of abduction, 30 degrees of flexion. Put that shoulder, that glenohumeral joint in as neutral a position as we can. What kind of external rotation do we have? If we have a loss of external rotation, we're assessing for infeel. Is it capsular or does it feel more elastic, which might suggest an anterior translation of the humeral head? Okay, so here's my etiology. I'm thinking it's poor scapulothoracic rhythm resulting from increased levator scap tone and poor upper thoracic mobility. I'm pretty confident in that at this point, based on my results. Okay, so here's the question. Who wants to give me, we got a couple minutes here, who wants to give me how they treat this patient? What comes first? How do you prioritize things?
I would start with treatment to the neck and CT junction is how I would start it to get the muscles operating better.
Okay, so as far as treating the neck, what's the treatment going to be, do you think?
Treat the craniovertebral dysfunction on the right, I think it was, right? Was it the
Yeah.
right glide?
Yeah, right OA posterior glide. Now
Yep,
it's a capsular end feel, and most
yep,
likely what happened is during that motor vehicle accident he had, is he
yeah,
banged up that thing, right? And so it got a little touch swollen. Probably didn't think too much of it. Yeah, I got some headaches. I got a little bit of soreness in my neck, but it went away a few weeks later. But then it stiffened, right? And so now he can't rotate his head very well because the CV region is kind of stiff. So he's taking that C23, that 2, and he's just pounding it down onto C3. So we got to improve the mobility of that OA joint. That
Correct.
to me that's priority one,
Yes.
right? And then you said CT junction as well.
Yes.
And we had what kind of infield did we have there?
Um, what was it? I can't remember. Pathomechanical. Yeah.
Nothing
So you
mechanical. So
could,
we're gonna do a manipulation, right? We're gonna
yep.
just go in there and we're gonna do what we do best. We're gonna manipulate that 2-3, T23, get that thing moving. And realistically, at that point, after that, once I've treated the OA and the C23, the manipulation of sorry, not C23, T23. Once I've done those two things, I should have a very nice window to be able to try and stretch and lengthen that levator scap. Okay, because now all of a sudden I've kind of reset that facilitation with the manipulation, right? So that's the plus side of the evidence in motion version of it doesn't matter what you manipulate, it's gonna fix things. It does. It fixes muscle tone, right? It gives us kind of this neurophysiological reset, right? So that's a great thing. So we can go in and we can do that sort of thing. And again, we'll show you how to do some stretching, some of that sort of stuff, this contract relax type of stuff to help lengthen that tissue. Um, but as far as what is the priorities for me is I got to regain this motion, CT junction, um, and CV region. And then I also have to work on improving the range of motion of the AC joint. Those are my priorities is restore that motion and maintain that motion. After that, designing a rehab protocol is I got to give them some things to help maintain the motion of those three areas that we just talked about. And then I've got to kind of slowly build up some of the recruitment of the muscles that have been inhibited, right? So if I'm looking at increased tone of the levator, well, its functional antagonist is the lower portion of the serratus anterior. So I need to work on improving tone there, right? Improving recruitment there. The inability to get into a full overhead position, I'm looking at the lower trap as probably being one of our major issues. So I have to find some ways to work on that. And then, from there, it's all about kind of building from individual piecemeal components to a gross motor component, right? So building from I'm just focusing on the lower trap to now I'm focusing on the whole movement, right? So um, more that we can talk about there as far as the rehab component stuff goes, because with the shoulder girdle, I feel like it's almost even more important than it is in the lumbar spine, SI joint region, all these different things, just because it seems like such a delicate mechanism for things to go wrong. Um, so again, a lot more that we can talk about there, but that's a very common profile, that you'll see is just this abnormal position that's affecting, kind of the ability of the biceps to clear that acromion. If it doesn't clear it very well, then you're going to end up with some impingement issues. So pretty simple stuff, I think. I mean, it took us an hour to walk through it, but it is relatively, if you look at it, not that difficult to kind of follow. So chew on that, guys, for the next few days here. Look at it from the patient's perspectives that you guys are seeing, and hopefully, if you guys have any questions, we can discuss this, coming up next week. Okay. Anything else? Any questions before we go? All right. Very good. I'll talk to you guys in a week.